Good afternoon. My name is Monique Wilson, and I'm with the American Heart Association. Today, I'm here to talk to you about the American Heart Association's Target BP program, which is a collaboration between the American Heart Association and the American Medical Association. So the reason that the Heart Association has decided to focus in even more so in blood pressure is due to the 80 million adults that have high blood pressure. Today, 1 in 3 Americans suffer from high blood pressure. However, we know that the prevalence of high blood pressure greatly varies among race and ethnicity. As you can see, 1 in 3 whites have hypertension or high blood pressure, while 2 in 5 blacks, 1 in 4 Latinos, and 1 in 5 Asians. So why is controlling blood pressure important? It has been found that in people with hypertension and elevated blood pressure, when lowered, greatly can improve the health of vascular or prevent vascular damage to organs. So that is heart disease, stroke, eyes, kidney. We've known for years since the 60s that there are certain drugs that can treat hypertension and reduce the rate for heart disease and stroke. And with that, we can reduce morbidity and mortality due to cardiovascular disease by directly working with patients with blood pressure. We have a goal at the American Heart Association, and that's to move 13.6 million people to control by 2020. So with that, we have several aims. One, of course, is that more people would be diagnosed with hypertension, but not only diagnosed, but are controlled by providers and are treated in a way that they themselves can learn how to be a partner with their provider. So in 2013, the American Heart Association partnered with the American Cardiologists as well as the CDC to produce a scientific statement that recognized best practices in clinical care around systems approach to blood pressure care. This was a collaboration to produce guidelines that really encourage an algorithm approach to treatment. So if a patient comes in and they present with a certain blood pressure, it would be an algorithm that would say, if this, do this, if this, do that, and definitely would give clear guidance and understanding to providers in order to allow for consistent treatment of patients. At that time, interestingly enough, the American Heart Association began working with the Alabama Department of Health as a part of the statewide Alabama Task Force focused around blood pressure adherence. And as a result of those conversations, the Alabama Department of Health themselves decided to adopt an algorithm consistent with the given guidelines to be utilized in clinics throughout the state in their coverage area. So setting that example to other providers that it's important that we have a quality system of care in which we are diagnosing and treating patients and partnering with patients in order for them to control their blood pressure. So in 2015, the AHA began a focused drive to promote and implement the algorithm among healthcare systems. And as I mentioned, the Alabama Department of Health was an early adopter, one in the nation, to actually start training their nurse practitioners and their providers about the importance of a system approach to blood pressure diagnosis and treatment. And so with that began the evolution of what we call the Target BP program, which again is a program that is combined between the American Heart Association and the AMA. So what is Target BP? Target BP is a call to action motivating medical practices, practitioners, and health services organizations to prioritize blood pressure control. It also provides recognition for those providers who are attaining high levels of blood pressure control. So that means of their total patient population, of those that are diagnosed with hypertension, that 70, 80, or higher percentages are actually at control. That means that the provider has partnered with those patients to ensure that they are at a safe level. And then the Target BP program also serves as a tool, a source for tools and assets and resources to ensure that those things are easily at the fingertips of providers in order for them to effectively treat their patients. One of those tools, which I'll talk about a little bit later, is around the AMA's M.A.P checklist, which is a tool that providers can use to assure that they get to the 70, 80% and higher control rates within their clinics. So our target audience for this program really is the provider level. So we're looking at primary care systems, primary care providers, so that includes federally qualified clinics, rural health centers, private practices, and really we have a special focus on those that service underinsured and uninsured individual. As you know, hypertension, as I mentioned earlier, there are a lot of disparities that span the gamut, whether it be race or income. And so in order to really address those disparity rates, we really want to work with those providers that are treating those patients that are highest at risk. But we're also looking at private clinic systems as well as governmental agencies and organizations that provide care to patients. So why did we decide to launch Target BP at that point in time? Directly prior to us launching the SPRINT study, which was a national blood pressure study around the importance and the benefits of lowering blood pressure, the results from that trial were released. We also saw that there was increased access to care due to the Affordable Care Act. And then again, the AHA, our 2020 goals really were a driver for us. The American Heart Association has a goal to improve the cardiovascular health of all Americans by 20% while reducing death and disability by 20%. Since we're almost to that goal, it's now 2017, it's really important that we decide which risk factors really will give us the best return on investment. So by having some established national partners that can work with us in local communities to really drive home those risk factors that will make the biggest impact, we felt that this was a great time to launch a program such as this. So why should a clinic participate? Well, we know what medicines work, but systems aren't always in place to drive control rates. Algorithms and systems approach that are described in the AHA, CDC's, and the ACC's algorithm are proven to increase control rates within a clinical setting. And sites will receive recognition. So to be able to be given a map that really shows you how to get your patients to control is really an advantage to providers who are struggling with getting their control rates for their patients to a certain level. It also helps them meet required performance metrics. Clinics already are required to meet certain outcome goals and report certain patient data. This is a tool that will help them get there and ultimately improve the health and care of their patients. So as a part of the Target BP recognition program, we've created 3 levels: participation, improvement, and achievement. So participation is just as it stated. This past year, we had our first year of providers that were recognized as simply participating in the program. That means they're taking steps and measures to improve the control rates of their patients. As a part of that, we were able to recognize them locally as well as on a national platform at AHA international sessions such as scientific sessions. They also included improvement in blood pressure control, and at that level, we just want to see that there's some improvement from one year to the next. And then achievement, and that's really meeting those high metrics of 70, 80, or 90% and above. So this will also provide performance and benchmark data for providers, which is very important to ensure that all of their providers are treating patients at the same level. It also accommodates either self-reported aggregate data or patient population data. Again, all of this information is information that providers are already providing and already collecting. When providers sign up for Target BP, they simply need to know 3 numbers, which they most always know, and that's their total patient population, their number of patients that are hypertensive and then the number of patients that are hypertensive that are at control. And the goal is to move that number of control, whether it be 40, 50, 60, up for the next year. And then this program also offers opportunity for improvement and achievement through adoption of the program and implementation of the tools and resources. And so key to the Target BP program is a MAP overview. And this is something that the American Medical Association has tested, and it's tried and true. And it's really a process to ensure that we are meeting the patients where they are and really seeing improvement. So we know there's some barriers to success that oftentimes patients or physicians may mention. So we know from patient factors, it's oftentimes non-adherence. So they may get a prescription, but are they able to refill that? Are they taking that prescription as required? Those types of things. Also, sometimes there's financial challenges in regards to cost of blood pressure prescriptions. We do know now that there are a lot of providers as well as retailers who offer low-cost blood pressure medications. Also, literacy sometimes can be a factor. Health literacy always is a key. And so then physician factors, again, the time that a provider must spend with a patient in order to figure out exactly what they need to get that patient to control, in addition to financial factors and knowledge of the evidence and why it works. We also know oftentimes it's systems factors, whether it's workflow or leadership buy-in or quality reporting. All of those can make a big impact into the success for blood pressure systems within a provider group. So with that, the MAP framework has definitely been something that has been found to be very successful. The M in MAP stands for measuring blood pressure accurately every time. So there are several factors that can impact blood pressure readings, and it's really important that all providers at all levels, all clinicians in a provider setting are equally trained on how to measure blood pressure accurately. That means that patients should be seated with their feet flat on the floor, not crossed, arms not dangling. They should get a moment to rest if they're in motion. They should not be speaking. Those types of things are important that not only the provider knows, but that the patient knows. It's also important that A for act rapidly. So the A in MAP is to act rapidly to manage uncontrolled hypertension. That means when someone presents with hypertension, that we are having them promptly come back in for additional readings. We do know that there's such things as white coat syndrome, and there are stress factors and all of those things that can be a trigger for elevated hypertension or elevated blood pressure from one reading. But that's why it's important when a provider sees that there's elevated blood pressure that they act rapidly to do follow-up to determine if this is a chronic condition or not. And then the P in MAP really stands for partnering with patients, family, and communities to promote self-management. So we know that providers have a big goal in front of them to help their patients. But at the same time, the patients have a need to really partner with their providers. That means them understanding themselves how to self-manage their conditions. And that means healthy lifestyle. Sometimes that means self-blood pressure management and self-blood pressure reading. But those are the types of things that a provider should be working with their patients and their families and the community at large in order to make sure that the patients are an equal part of the treatment. And so that is the Target BP program for the American Heart Association. If you are interested in registering or finding out more information, you can go to www.heart.org/BP. We would love to have you join. And next up, we have Dr. Dunn, who will be sharing with you some more vital information.
My name is Donna Dunn. I'm an associate professor and the family nurse track coordinator at Jacksonville State University. I want to talk to you today about blood pressure and how to obtain an accurate measurement. Let's first begin by understanding what blood pressure is. When the heart pumps blood, the blood pushes against the walls of the arteries, or the blood vessels. And blood pressure is this force that is exerted by the blood on the wall of the arteries. This vital sign is extremely important and gives us information regarding a patient's overall status. Blood pressure is measured in two numbers. The first number gives the pressure when the heart beats as it pumps blood to your body. This is the systolic blood pressure and is typically recorded as the top number. The second number gives the pressure when the heart rests between beats. This is the diastolic blood pressure, or the bottom number. Blood pressure goals vary with age, sex, and states of physical, mental stress, and fatigue. Generally speaking, in a healthy adult, the blood pressure varies between 100 to 139 over 60 to 89 millimeters of mercury. It is extremely important to obtain an accurate blood pressure because blood pressure readings are used to initiate treatment and to monitor effects of drug therapy. A false low reading may lead to undertreatment, which can lead to more organ damage. A false high reading may lead to overtreatment and the possibility of drug-induced side effects. It's important that you follow a guideline in obtaining blood pressure. The first thing is to make sure that you're positioning the patient. The patient should be resting for at least 5 minutes before the blood pressure is taken. And this is important, especially in the busy clinics that we work in. Oftentimes, we'll have a patient who comes in and we take a blood pressure right away. But it's truly important to let this patient rest for at least 5 minutes before taking the blood pressure. It's also important that the legs should not be crossed and the patient's feet and back are supported. This means that the patient's feet are flat on the floor and they're sitting in a high back chair in order to give their back the support needed. Additionally, the patient should not be talking during blood pressure measurement. It's also important to choose the appropriate cuff size. Cuff size is determined by the circumference of the arm, not the age of the patient. And we'll talk more about this in the next couple of slides. When you're choosing the appropriate arm, you should not choose an arm that has a dialysis shunt placed, that's on the same side as a mastectomy, or on the side affected by a stroke. You should also try to use the same arm each time the blood pressure is taken. So let's talk a little bit more about the right size cuff in the right place. The inflatable part of the blood pressure cuff is the bladder, and it should be long enough to encircle at least 80% of the arm. It should also be wide enough to encircle 40% of the arm at the midpoint. The lower edge of the blood pressure cuff should be centered 2 finger widths above the bend of the elbow, and the midline of the bladder should be over the brachial artery pulsation. And if you remember, the brachial artery is the artery that goes along the inside of the arm, and it's important to palpate this pulse in the brachial artery. It's also important to remove any obstructive clothing that's between the blood pressure cuff and the arm. We know that sleeves of shirts can actually decrease the ability to hear the pulse sounds. So if you have someone that has a shirt that can have the sleeve being pulled up, it's important to go ahead and pull that up. If it's too tight and it can't be pulled up, then it's important to take the arm out of the shirt altogether in order to properly obtain a blood pressure. You then begin to place the cuff on the arm, again checking the size and the placement by using the arrow or symbol on the cuff that should be over the artery. You can proceed then to loosen the stopcock on the bulb, which will let any air that has been retained out, and then you begin to turn it several times to close it. You place the blood pressure gauge in a good view where you can read the readings and the numbers when you take the blood pressure. The patient's arm should be supported, relaxed, and placed at a level even with his or her heart. And then you begin to take the blood pressure. It's important to ascertain before you begin the blood pressure what a normal systolic pressure is for your patient. Once you know that information, inflate the bladder of the blood pressure cuff quickly, 20 to 30 millimeters of mercury above the patient's usual systolic pressure. While listening over the brachial artery with your stethoscope, release the air slowly at about 2 millimeters per second. the first 2 beats heard is the systolic pressure. You'll then begin to hear a muffling sound with the beats, which is the first diastolic, and then the sound will completely disappear, which is the second diastolic. For blood pressure measurement, it's important to record the systolic pressure and the second diastolic, which is where the sound disappears, as the patient's blood pressure. We've given you guidelines to follow in order to obtain an accurate blood pressure, but what happens if you don't? Or what happens if you have a cuff that's too small? Here's a table that shows you what can happen whenever you do not follow the guidelines and how it impacts the blood pressure readings. If you have a cuff that's too small, it can drastically increase our systolic blood pressure readings, or if there's a shirt in between the cuff and the arm. If the back and the feet are unsupported or legs are crossed, that also can increase our blood pressure reading, as well as the arm being tense. And look at this, not resting 3 to 5 minutes can actually increase our systolic blood pressure reading 10 to 20 millimeters of mercury, which is a drastic increase and can impact our management plan. If the patient talks or they're having laboring breathing, that also can increase our systolic blood pressure. And the placement of the arm. So if the arm is above or below the heart level, that impacts our blood pressure readings. For every centimeter above or below the heart, blood pressure varies by 0.8 millimeters of mercury. Blood pressure measurements are extremely important. We know that high blood pressure is a major cause of heart attacks, heart failure, kidney damage, blindness, dementia, and strokes. And treatment of high blood pressure can dramatically decrease the risk of poor outcomes. I've given you some references that you can use to go and look at the toolkits and other information to help you know how to accurately take a blood pressure reading. Now stay tuned and we're going to watch a video that shows you and demonstrates how to accurately take a blood pressure.
This is a video in clinical medicine from the New England Journal of Medicine.
Evaluation of blood pressure is essential in assessing cardiovascular health. It is used in screening for hypertension and for monitoring the effectiveness of treatment in patients with established hypertension. In the routine outpatient setting, blood pressure is measured indirectly. Thus, it is important that proper techniques be used in order to produce consistent and reliable readings. In adults, a normal blood pressure is less than 120 millimeters of mercury for systolic and less than 80 millimeters of mercury for diastolic blood pressure. Higher levels are classified as prehypertensive asystolic blood pressure between 120 and 139 millimeters of mercury and a diastolic blood pressure between 80 and 89 millimeters of mercury. Hypertension is defined as a systolic blood pressure greater than 140 millimeters of mercury or greater than 90 millimeters of mercury diastolic measurement. The purpose of this video is to demonstrate the appropriate technique for the indirect measurement of blood pressure in adults. Blood pressure should be assessed at each office visit. The equipment necessary for measuring blood pressure includes a stethoscope. The stethoscope should have tubing of sufficient length for the clinician to hear Korotkov sounds while viewing the manometer. The bell side of the stethoscope should be used as it permits better auscultation of Korotkov sounds. A sphygmomanometer consisting of a blood pressure cuff containing a distensible bladder, a rubber bulb, and an adjustable valve, as well as flexible tubing. Finally, a manometer that documents the level of pressure within the cuff. Each part of the sphygmomanometer should be examined on a regular basis. The needle on an aneroid manometer should rest at 0 before and after measuring blood pressure. Aneroid manometers should have scheduled recalibration at least every 6 months. Concerns over the toxicity and environmental impact of mercury have led many institutions to use aneroid manometers exclusively. The steps required for accurate indirect measurement of blood pressure are identical whether using an aneroid or mercury manometer. Correct positioning of the patient is essential to accurately measure blood pressure. The patient's back and legs should be supported with legs uncrossed and feet resting on a firm surface. The patient's arms should be bare to the shoulder. The arm should be supported at heart level. The manometer should be at the eye level of the healthcare practitioner. A common error in taking blood pressure is the use of an improperly fitted cuff. Selection of an appropriately sized cuff requires assessment of the arm circumference. The midpoint position is determined by measuring the distance between the olecranon and acromion processes. The arm circumference is then measured at the midpoint. Once the arm circumference has been determined, the appropriate size cuff can be selected. Cuffs typically are marked with acceptable sizing indicators to facilitate proper fitting. However, it is more important to use a cuff that is appropriately sized for the arm. To assist in selecting the appropriate size, cuffs should be marked with an index line that runs perpendicular to the length of the cuff and a range line that runs parallel to the length of the cuff. The index line should fall within the range line when the cuff is secured to the upper arm. The cuff should be applied 2 centimeters above the crease of the elbow. It should fit snugly, but still allow 2 finger widths under the cuff. Next, find the brachial artery, which is palpable approximately 4 to 5 centimeters from the medial epicondyle on the anterior surface of the elbow. Place the stethoscope lightly against the skin over the brachial artery. There should be appropriate pressure to ensure good sound transmission. The stethoscope should not be in contact with clothing or with the cuff. Inflating the cuff to some arbitrary level runs the risk of excessive overinflation. To avoid this, determine the measurement of the pulse obliteration pressure. Rapidly inflate the cuff to 80 millimeters of mercury while palpating the radial artery pulse. Continue to inflate in 10 millimeter of mercury increments, taking note of the reading at which the pulse disappears. Then deflate the cuff at a rate of 2 millimeters of mercury per second, noting when the pulse reappears. Once the pulse obliteration pressure is determined, you are ready to measure the blood pressure. Inflate the cuff to a level 20 to 30 millimeters of mercury above the pulse obliteration pressure. Then, deflate the cuff at a rate of approximately 2 millimeters of mercury per second while listening for sounds. As the pressure in the cuff is decreased, blood flow in the brachial artery increases, creating turbulence, which generates carot cough sounds. Phase 1 sounds are clear, repetitive tapping sounds that coincide with reappearance of a palpable radial or brachial pulse. The onset of Phase 1 sounds are equivalent to the systolic blood pressure. Phase 2 sounds are audible murmurs in the tapping sounds. Phase 3 and 4 sounds are muted changes in the tapping sounds that occur as the pressure measurement approaches the diastolic pressure, usually within 10 millimeters of mercury of true diastolic pressure. Phase 5 sound is not really a sound, but rather is the level at which sounds disappear. Phase 5 indicates the diastolic blood pressure. To ensure that diastole has been reached, the cuff pressure should continue to be deflated for an additional 10 millimeters of mercury beyond the 5th carot cough sound. You should measure the blood pressure twice at a minimum, waiting at least 1 minute between readings. The average of the measurements should be recorded. In the following example, the patient's blood pressure is 116 over 90 millimeters of mercury. You will hear nothing until the first carot cough sound appears at 116 millimeters of mercury. The various phases of carot cough sounds will be heard until their disappearance at 90 millimeters of mercury. An auscultatory gap is defined as the intermittent disappearance of the initial carot cough sounds after their first appearance. This phenomenon can lead to underestimation of systolic blood pressure. Obtaining the pulse obliteration pressure can be helpful in avoiding incorrect measurement. In the following example, the systolic blood pressure will be heard at 162 millimeters of mercury, followed by an absence of sounds for 4 millimeters of mercury, after which they will reappear. Certain conditions may complicate blood pressure measurement or interpretation. In such settings, decreasing the rate of deflation and averaging several readings may improve accuracy. Observer bias is usually the most common error that occurs in blood pressure measurements. It occurs because practitioners often show digit preference and/or rounding of the terminal digit. When two people use the same correct technique for measuring blood pressure, there should be little inter-observer variation. Measuring blood pressure correctly is required to classify individuals, to stratify their cardiovascular risk, and to monitor the effects of treatment. This video provides the viewer with a standardized methodology that, when followed, will lead to accurate blood pressure measurement.
I'm Dr. Mary McIntyre. I'm the Chief Medical Officer for the Alabama Department of Public Health. I've been asked to talk to you today about Blood Pressure 101, or basically how to make sure that you're taking the correct blood pressure and getting an accurate reading. I will also be covering M.A.P framework, and this deals with making sure that we're looking specifically at some specific indicators when we're looking for, at whether or not we're controlling hypertension and how that should be done. So when we look at most clinic visits, when they start, what happens is we really end up trying to make sure that a blood pressure and a weight is taken. Now, this is often done when people come through the door and not giving them enough time to actually sit down and to actually rest so that a blood pressure and stuff will be correct. So together, what we're going to look at is how to make sure that these two indicators, that we are getting appropriate readings for them, because this is extremely important in determining whether or not a person does have hypertension. Hypertension itself, we know, is known as the silent killer, and it's appropriate to make sure that that reading is correct when it's actually taken. There are several risk factors for uncontrolled blood pressure. We know that some of those risk factors are hereditary and not actually addressed here, but most of us know that uncontrolled blood pressure can have numerous effects, affect the heart, affect causing strokes, that we can actually have issues and problems with the kidney and also with vision as a result of not having our blood pressure controlled. So hypertension can have serious repercussions. Therefore, it's very important that we do obtain accurate readings. There's even some information and evidence to support that there are some forms of cancer that's related to uncontrolled blood pressure. So the American Heart Association, Mrs. Wilson has actually talked briefly about the M.A.P framework, and so I will be providing some additional details related to this framework when it comes down to measuring, acting, and partnering when it comes to controlling hypertension. When it comes to measuring the blood pressure accurately, technique is important. It is easily to actually slip into the habit of doing blood pressure readings incorrectly or measurements incorrectly. And I don't know how many of you actually, when we go through this information, will notice that your blood pressures that are being taken may not be being done correctly. So it's going to be extremely important to pay attention to the appropriate way to do this. And I have even often gone in when people are taking my blood pressure and asked for it to be repeated because the technique was not done correctly. So there's even been one pediatric clinic that actually has placed different size chairs in a blood pressure room that will allow for appropriate placement of the arm so that it is right at the heart, not below or above it. And there are many internists that are actually starting to actually create a blood pressure room so that people will have the ability to be able to calm down before a blood pressure reading is taken, and so that the blood pressure reading is also done correctly. So when we look at the measurement of what I've just covered this, but when we look at the accurate measurement of blood pressures, it's important to actually look at what are some of the things that can be done incorrectly. You know, we all know, I think everyone probably knows that too small of a cuff or too large of a cuff can actually affect whether or not the blood pressure is correct or not, but there are other things that will impact it as well. So when we're looking at proper technique, one of the important things to do is to make sure that the right arm is recommended to be used for the blood pressure reading, because there can be a difference between the two. With the palm facing up and that arm actually kept at mid-heart level, not down or up, because the impact of that difference can actually mean that you've got a lower blood pressure reading than it should be, or a higher blood pressure reading than it actually is. So the back and feet should be supported. The feet should not be dangling. They should be kept so that they're on the floor. The legs should not be crossed, not at the ankles, nor at all. And the person needs to be actually relaxed and calm. Some people actually do some slow breathing in order to make sure that they have an opportunity to get their heart rates down so that their blood pressure reading will be correct. There is a type of hypertension called white coat syndrome, or hypertension is really that occurs in people that get really anxious, and sometimes they may not even know that they're anxious. And as a result of that, their blood pressure readings will be elevated when they go into the doctor's office, but normal when those blood pressures are taken at home. That's known as white coat syndrome, and there are some people that just with being in the physician's office alone is enough to bring their blood pressure up anywhere from 10 to 30 millimeters of mercury, which is significant in trying to determine whether a person has hypertension or not. I've seen some of those patients over the years, and what I found is that if I give them time to relax, usually if they also come to know you and then you retake that blood pressure, you'll notice that it's now normal. And so that person does not actually have hypertension. In addition to anxiety, there are a number of other things that actually can impact whether or not the blood pressure is normal. We ask people not to smoke, not to drink alcohol, and to avoid coffee for at least 30 minutes before those blood pressures are taken. And people don't often think about the coffee piece, but it can actually cause the blood pressure reading to be higher. So let's make sure that those are some of the things that you remember when you're actually going in to get your blood pressure taken. So we've talked about some of these, but we wanted to actually demonstrate or show pictures of what we're actually just talked about as far as those factors that can impact whether blood pressure is correct or not. We're looking specifically at making sure that blood pressure is being taken correctly. Now, we talked about the arm being supported. It doesn't mean you holding the arm to get the blood pressure, which is what this person is doing. And it's not exactly right at arm level. There is if you'll notice how the hand is being held, okay, there's actually some downward motion as far as being held with that hand being held down. Her back is also not really supported the way it should, and they appear to be having some kind of conversation, or at least from the standpoint of looking at them, that there's smiles on one face, the other one seems to be laughing. And believe it or not, you really shouldn't be talking and carrying on a conversation when the blood pressure is being taken, because it can impact and make a difference as far as to whether that blood pressure is normal. So when we're looking at a normal BP of 110/75, in actuality, the reading and stuff can come back elevated because of the problems noted with, and the errors are demonstrating the ones I've just talked about, and the impact that that can actually have. And you see each one of the little pointers as far as with what is not correct. So instead of it being that 110 over 75, it is 140 over 90. So now this person has been identified as potentially having hypertension, and she doesn't, because the problem that we're actually looking at is related to technique and how the blood pressure was taken. So let's look at another example, and this encounter actually exhibits even more factors that can actually skew the BP reading. Once again, her back is not supported. The blood pressure reading for this person should be 110 over 75, but you're going to see what happens because of technique alone. We're looking at where we should have as far as with the arms, her feet dangling, even though that's not look how she has her legs crossed at the ankles. And we did mention this a little bit already. And look where her arm is held down, and it's way down. The other one, there was just a little bit of a slight decline in where the hand was down and not quite at heart level. This one is nowhere near heart level. It's actually pointed downward and significantly below heart level. So what we're looking at is all of these factors that can impact that blood pressure reading. And so when it would be 110 over 75, what did we get? 160 over 92. So it's even higher than the previous example when we are actually looking at some minor, alterations in how it should be done. And these are pretty major, so the blood pressure is even higher. So this person would be actually identified as hypertensive, especially if this is the way the blood pressure is taken all the time, because we should not react to just one blood pressure reading. There should be multiple readings. And this particular person has a BP that's pretty significant. And if the next time she comes in is taken that way and we get the same reading, she's going to be classified as having hypertension when she doesn't. So how a blood pressure reading is obtained is extremely important. So let's look at the next piece of the M.A.P framework that talks about act rapidly to manage hypertension. The CDC and the Million Hearts efforts have been working to actually identify key problems that many patients have with hypertension that have not been diagnosed. And so the information is being put out there is to actually identify people with hypertension that have been undiagnosed and to actually get them into treatment and control of the blood pressure. So we're going to look at the use of the blood pressure protocol and algorithm that can be used either manually or embedded into an electronic health record, so that we are looking at multiple high blood pressure readings being able to trigger an alert, and that alert itself would then allow for evaluation of that person to determine whether or not they have hypertension. We've already talked about white coat syndrome, and I've talked about the fact that it can often confuse the scenario as far as whether or not a person has hypertension. But you can deal with that by making some modifications like the blood pressure room that we talked about, giving a person time to actually relax, and if necessary, giving them equipment to take their blood pressure in the home setting where they are not influenced by being in a doctor's office and getting an abnormally high reading when they have normal blood pressures the majority of the time. So Alabama's blood pressure protocol, Alabama is just it's the first state to actually adopt a BP protocol and algorithm. That BP protocol and algorithm can be customized to the provider's preferences, and we talked about it being either used manually or being embedded in the electronic health record. That customization is according also to the doctor's preferences of the JNC 7 guidelines or the JNC 8 recommendations, which can be built into that protocol. It can easily be modified to suit a particular provider's practice or their preferences. So this protocol protocol is available for download. And this, actually, there's a link here with information that you can go to that is on the ADPH Cardiovascular Health's website. If you follow the link that's included here, it will take you to the information that you need in order to get that protocol. It is currently being used by several of the Alabama Department of Public Health's county health departments, and it will also be, once we actually do get our electronic health record statewide, we will be actually incorporating it not just manually as it is being used now, but as part of the electronic health record, so that it would be being used in all of our clinics. So when we look at the P part of the M.A.P framework, it deals with partners. This is not just about the physician's office and blood pressure readings being taken when you go in to see the doctor. It's also about using the partners that we have, whether that partner is a church, whether that partner is a barber shop or a hair salon, and also there are other entities that are working with us to actually do this, and that include other partners. And these partners together makes up that P for the M.A.P. And it's all about promoting self-management of hypertension. While a physician may make the diagnosis and get the medication started, you're not going to get control of your blood pressure or hypertension unless there's adherence to medication. There are many reasons that people often don't take medications or take them appropriately, and we will deal with some of those in just a minute. But it is important that we note that adherence to medication schedules, that if it says medication should be taken twice a day, that doesn't mean to take a pill at 8 o'clock and another one at 10 o'clock, okay? So we will actually go a little bit into about dosing schedules really near the end. So let's look at all of the things that we need to look at. Medication we just talked about. But one of the most important factors that can actually impact and lead to control of hypertension are lifestyle interventions. These are things like diet, exercise, making some changes, reduction of the salt intake. And these are things that we talk about because there are specific interventions like the DASH diet, which has really been demonstrated to work along with the Mediterranean diet. Dietary approaches to stop hypertension is DASH. And it's really about making sure that certain foods are incorporated, fruits, vegetables, reducing salt intake. Mediterranean diet, making sure the appropriate mix of reducing carbs, the sugars, increasing the important oils like the olive oil so that we're staying away from saturated fats, and not eating a lot of red meats. All of those things are important. And in addition to that, the diet piece of it, there is the exercise piece. That doesn't mean that you have to go out and run a marathon. But what it does mean is that we need to be getting some regular exercise, even if it's walking. Walking is an excellent source of exercise. And it's pretty much something that most people can do. Now, I recognize that there are some that have some limitations when it comes down to mobility, but even people that have mobility limitations can get exercise. There have been identified specific exercises for folks that are even chair-bound that can actually get activity in. So there's no reason that any of us shouldn't be able to have some regular form of increased activity that will help us make those changes and the modifications that we need in order to control our blood pressure. So let's talk about self-monitoring programs. We talked about the physicians getting the blood pressure taken. We talked about partners, and we talked about how it's extremely important to work with partners, including our churches. Many of them have incorporated health programs within their churches where they take blood pressures for people. So it's important for them to make sure that it's being done correctly. I actually helped founded a program in our church. We had to first train people, even though these were folks that had health backgrounds, to make sure that they were doing their blood pressures the correct way. to give people time to sit down, that their arms were appropriately supported, those type of things. And there are other partners that we can work with, and the Y is one of those partners. So when we look at the YMCA, it is actually collaborating with the American Heart Association in a BP monitoring a lifestyle change program. Many local providers will be referring their patients with hypertension to the YMCA. When a client signs up for the blood pressure program, they can also purchase a membership that is discounted that would allow them to incorporate exercise into their routine. So this brings two of the important elements together in self-management, and that is looking at the exercise piece and also looking at the lifestyle modifications, including exercise. So this is there's another valuable tool that is available on the American Heart Association's website. Sorry, I almost said ADPH again, but you already have that link. The American Heart Association and many others also have phone apps. Most of us now have we walk around with our smartphones, and there's really no reason for us not to have the availability of those apps that can help us with anything from eating appropriately, whether we're cooking or whether we're purchasing foods in the grocery store, whether we're out trying to get exercise in. And I forgot this morning, I plugged in my, I have a Fitbit that I wear, but I plugged it in to actually, because the battery was low. I mean, there are so many resources that are out there that are available that are not expensive at all, that we can use to help us do better, but they only work if we actually utilize them. So I'm going to actually show you a few of those apps that are now available. This does not include all of them, but there is a new American Heart Association On The Go called On The Go app that is available for healthcare providers. There are also all kind of apps when it comes down to diet, the DASH diet. If you look at this, it may be hard to see, but there are apps there talking about stepwise. There's information about Live Strong, which is really a smoking cessation app, which is extremely important if we're talking about controlling hypertension and preventing the complications that can occur, like heart attack and stroke. There's a Spot a Stroke Fast app, there's a Fitness Pal, and then some of the ones not shown also include the apps from the diet tracker. There's one that I use, and it's called Calorie King. I love it. There's also one that you can purchase. I mean, not purchase, but there's a Pro Tracker that you can use. And there are many apps that are available that are not, that I didn't even mention, that you can go to the lifestyle section of the little app store, like your iPhone or your Droid, and actually pick up one of those apps. At one time, I had too many on my phone, so I had to actually determine which ones I would actually use. So identify an app when it comes down to making sure that you can make the right food choices. Get you another one to help you with making sure you're getting in your exercise on a daily basis, and stick to it. The only way that this is going to work is if you're being consistent and you're following through with it. So when we look at barriers to success, I've actually mentioned several of them, or many of them, during the presentation itself, but one of them is cost. You know, a lot of people talk about how expensive stuff is, but guess what? You know, I've heard my family members say, oh, to eat healthy is expensive, because they're talking about the cost of the foods themselves. But guess what? You can make healthier choices and not really make significant increases in the cost of the food that you buy. I'm going to give you some examples. We tell people often to stay away from canned foods because of all of the sodium that's in them. There are now alternatives that may cost just a few cents more, that have no additional salt added to them at all. There are low salt alternatives, and for those people who still may have to use the foods that they have available, rinse those foods. At least you're reducing the sodium in them when you don't pour the stuff from the can and just cook it in that juice. Rinse that, remove it from it. At least the salt content is reduced from what you would have had, and you haven't spent any additional money doing that. Fresh frozen foods are an good alternative. If you can't get the fresh produce, then get frozen produce. Just read the labels and make sure there's no added sugar, no added sodium to the food that you purchase that's frozen. Read the, it talks about reading medication labels here, but you also need to learn to read your food labels to look at content as far as the sodium amount and also sugar content. Reading medication labels, a lot of times people may not say that they're having problems with understanding, but the example I gave a few minutes ago of when we had a person where the medication says to take twice a day, and the person takes the medicine at 8 o'clock and then takes another pill at 10 o'clock. Normally when we see twice a day, we're talking about spacing those medicines out where they're pretty much evenly spaced. But I always make sure, and I try to focus the patients exactly. I would ask them what time would they get up. You know, what time do you go to bed? Try to make sure you're dealing with a thing where you take this one either before breakfast, with breakfast, after breakfast, that type of thing. And if we're talking about twice a day, you need to have a minimum of at least 8 hours in between that, ideally 10 to 12, but don't take it any closer together than 8 hours, to give people ideas of exactly what we're talking about. For those people that can't read, and often you won't know that unless you start to try to figure out, well, what's wrong. Doing a medication count and realizing that there are medications that is lasting longer than it should. Okay, trying to find out when they last filling medicine or looking at those bottles. And when you actually identify that what's happening is that person actually doesn't know what the label is saying, you can come up with ways to help the person. You can put numbers on the bottle. You can ask the pharmacist to assist. There are now, even with the containers that can be used, there are ways to actually even put labels that can help that patient know that when I'm saying 2 times a day, I'm telling you to take this at 8 o'clock in the morning and 8 o'clock at night, and actually write it out for them so that they know that that is what they're supposed to be doing with the medications. There are a number of things that can be done to assist people in getting rid of those barriers that would allow them to succeed. So let's make sure that we're focusing on making those changes and stuff and helping them to make those changes. There are additional, I've heard people say lack of time. And for people that are really, really busy, you know, when you worked all day and then you come home and you have to do homework with children, and then you're trying to do a quick meal, and sometimes it is quicker to pick something up that's fast food from the drive-thru and I'm not going to name any of them, but some of the fast food burger places. You know, we should think about that, we can make better choices. There are even things that talk about eating out and making healthier choices with the foods that we are picking up. But you can do some things like using your crock pot so that you prepare the meals and put them in there and they're ready when you get home. I mean, there's ways about taking and looking at those choices to do some quick things. You know, turkey burgers, they take no time to actually put in the oven and cook. And believe it or not, they're great. You can, by reducing the red meat intake and removing or reducing the sodium, you can actually use things like garlic powder to actually get people to get food that tastes good, but actually can be prepared in a matter of minutes, and you can eat it quickly. It also then reduces the cost, bored with your diet, because you keep eating the same thing over and over again. There are so many options out there that often people don't look at. So there are resources available on the websites that we've just talked about to help you move away from being bored with your diet. You know, if you're only eating chicken, of course you get bored. So you need to make choices so that you keep a variety going. And then there's the whole thing about ego or pride. Many people don't want to acknowledge that they have a problem. And it's like if we don't acknowledge it, it doesn't exist. But the reality is, whether you acknowledge it or not, and you have hypertension, you need to actually focus on making sure that you're doing the things that you need to do to succeed. So we're almost at the end, and we're looking at performance measurement. It is extremely important, and insurance companies, Medicare, Medicaid, are all now starting to award practices that succeed in lowering overall blood pressure of their patient base. Some things have even been changing. We're all familiar with the PQRS, but our newest thing now, which is basically switching some of these older performance measures to the new ones, is our M.A.Ps and MACRA that we're all hearing about, and that we should be doing, actually working to actually get those things implemented. There was recently, I know the Medical Association is doing some meetings across the state. I attended one here in Montgomery, and the whole focus was dealing with MACRA and trying to get providers to understand that some of the things that we used to call PQRS, and that we also, with this, from the standpoint of what we were doing with the meaningful use, they have new names. It's really just been flipped to the M.A.Ps and the MACRA, but it's still doing the same thing. So you're going to be measured as far as, and it can determine, especially with the Medicare piece now, what we're looking at that they're starting with, but other insurers will be going in this direction. Medicare is starting, and what is happening with Medicare is that this year, which is 2017, looking at the ability to be able for providers that either qualify for the, under these programs for the M.A.Ps, there are a few providers that are, as far as people that can be excluded, depending on very, very low volume, on whether or not they have to meet or actually do this for submission. But ultimately, that you can lose like 9% total reimbursement, okay, for actually not doing this. Well, that's pretty significant. That's almost 10%. So it's extremely important to know about this and to actually look and see what's coming. So this is a new federal change when it comes down to Medicare, but you can also believe that it'll probably be happening with already some of the private insurances are looking at something very similar. So if you're not aware of it, there's information on the Medical Association of Alabama's website, MASA. There's also info if you put in a capital M.A.C.R.A. or a capital M.I.P.S., you will be able to get all kind of information, including presentations that will give you a little information about this program. So this is all about performance metrics. So now I know I've covered this relatively fast, but I wanted to get through within the time we had. And I wanted to be sure that you all had the information that you needed. So for additional info, please visit the adph.org/CVH, looking at the cardiovascular health programs link to actually get additional information.